Hello, everybody. Welcome to our 2 o'clock Central, noon in Arizona time, overview of cannabis use and general health and oral health. So if you'd like to, it'd be really cool if you could put your video on so I can see your expression, seeing if your token on the side there, as long as we're talking about cannabis. Hopefully this will be a fun discussion, looking at a topic that's extremely relevant to today's medicine and oral health. I've started out a chat. If you'd like to jump in there, you may or may not remember when I believe it was President, oh my gosh, I just lost his name, Clinton, said that he inhaled but didn't breathe in. And it's like, yeah, right. But here we are in 2021, and the whole landscape of cannabis use has completely changed. Arizona has just recently expanded to recreational use, or they call it adult use. So I'm hoping during this time that we have together, I'll just share for about 45 minutes, 50 minutes of some information. I'll be watching the chat. I have it off to the side. And if you'd like to unmute and ask a question, I'll be looking for any hands raised. Not that I'm a whiz kid at Zoom, but after a year of slogging through it, I've learned a few things, but in any case, it's a fun topic. It's a crazy topic. It's an ever-changing topic. And I just am so thrilled to have you here, and I'm recording it. So if you know of colleagues who'd like to get kind of an overview of cannabis use and how it impacts their health and the benefits and the detractors and kind of where we're going. So with that brief introduction, again, just throw whatever you want to in the chat. What do you think of when you hear someone talk about cannabis use? Is it like, oh my gosh, we can't use it? Oh my gosh, it cures every disease known to man, or somewhere in between. So just feel free to put in there whatever you'd like. So I'm going to go ahead and start. Deb, did you want to say anything here? Nope. Okay. It's good to see you.
It's good to see you too. I'm just like, super excited about this talk.
Oh, okay. Well, everything I do, I kind of try and have fun. No pressure that Gayla's with me, but we're good friends, so we're okay. All righty, here we go. Cannabis use and oral health, but really I'm going to talk about general health as well. And this is in a 50-minute span. You really can't cover this topic. It is so complex and it is so multifactorial. But I am going to just give you kind of an overview and then some references and resources at the end. And hopefully, thinking about it, this is a burgeoning research topic. And this is a tremendous opportunity to, in our own specialties and interests, learn more about this. It's just an open landscape for research and publications. We have thrown ourselves into this topic legally, and we have no idea what the impact's going to be, which is horrifying. But we have an opportunity at AT Still to really do some groundbreaking research and assessments in this area. So I'll just share some different things and we'll see where this takes us. Okay. So you can't do anything without learning objectives. So there you go. We're just going to be basically looking at the forms, general knowledge, oral health risks. And again, this is for medical and dental. All of them apply. Any adverse effects of cannabis use. And I will be talking about THC and CBD specifically, but there are a gazillion other cannabinoids that have been identified. And then a patient assessment. How does this impact our actual patient care? So I've been involved in tobacco treatment assessment training for a long time, 24 years. And most of my research and publications have been around tobacco treatment and healthcare and oral healthcare. But I was asked by NIH to write the section on cannabis use and oral health in the upcoming Surgeon General's report. Well, we had a change in administration. It was supposed to have already come out, hasn't come out yet, but it's all done and it's been reviewed and it's ready to go. But I'm just estimating and hoping it'll actually come out 2021, because our last Surgeon General's report on oral health was in 2010. So that's where I spent a lot of time researching this. There are a lot of parallels to tobacco use, but many, many differences. So as I've mentioned, cannabis use is a very complex landscape. We still have the classification at the federal level of this drug as a federal class 1 illicit drug, which is defined as no currently accepted medical use and a high potential for abuse. Well, it's true. It is true. And that's why the feds haven't changed it. But they see what the states are doing, and it's inevitable. They're going to have to do something different about this so that the funds will be released and that wide scale research can happen. Without the class 1 illicit drug classification being lifted, it's going to be very, very difficult to do actual cannabis research for a whole variety of reasons. But fortunately, Canada and other places have legalized it, so we get to see the outcomes of their legalization of recreational use. But in any case, we are embracing the expansion and legalization of both medical and recreational cannabis use. You can't see my PowerPoint. Oh my goodness. Oh, you know why? I'm sorry, I should have said that. Someone stop me. This is so funny. Okay. So much for my razzle dazzle of use of PowerPoint, for crying out loud. Okay, can you see the main screen? I'll just watch chat. Not the presentation screen, but can you see my slides? I'm watching chat, or someone unmute.
Yes, we can see.
Oh, perfect. I'm so sorry. Least I make you dizzy. I'm going to go back and just show you. There's my first slide. My learning objectives, and there's a little bit about the Surgeon General's report, and then where I'm at now. So my apology. There's restricted federal research funding, and therefore most of the more recent publications are case studies. There is some research, or actually quite a bit of research pre-war on drugs, putting cannabis into this class 1 illicit drug category. And then after that, there's just kind of this desert of good quality cannabis research. There was only one university, I believe it was in Mississippi, who could actually cultivate cannabis and was designated as the place to get the cannabis for research purposes. But the constraints and the costs were quite high. Nonetheless, the legalization of cannabis has been driven by industry. Imagine that. Just like tobacco expansion, there's a lot of money to be made by cannabis production and sales. And so a good deal of the lobbying that occurred in different states was funded by the cannabis industry. And in Illinois, which is where I live, this is a little old, but nearly $40 million worth of marijuana was sold in Illinois the first month of legal sales. And all over Illinois, there are registered cannabis dispensaries where you can access cannabis for any reason. And we'll talk a little bit more about that. So how likely as a healthcare provider are you to encounter a cannabis user? Well, the answer to that is very likely. It's the most commonly used addictive drug after tobacco and alcohol. It's growing in popularity, especially with teens, since, you know, those vaping pens, the jewels, all the different mechanisms that people vape with. Just think of that being loaded with THC and nicotine, and that hitting that developing brain. What a nightmare that is to a lot of our teens. And it's a growing epidemic. We have a huge problem that needs to be brought out, just like tobacco use was earlier on. But for now, people just see the vapor and think it's fine, but it's not. And with nearly 4% of 12th graders saying they vape THC daily. It's now recommended that all healthcare providers screen for cannabis use. Well, you may ask, well, my state doesn't have it, it's not legal. How can I ask about that? Well, we do ask about other illicit drugs, especially if we're going to use local anesthesia. There are drug interactions that we have to know about. We ask about tobacco use. We ask about alcohol use. So these are, we just need to include it in our medical records, our dental records, and ask every single patient, I would say 12 and up, if they are vaping, if they're using tobacco products, if they're using any cannabis products. It'll take a little while for us to get used to it, but we really want to move on that quickly. So in 2018, which is the latest data that I could come up with as of this morning, when I wanted to update these slides, you can see the number of users in the United States, and it has to be much higher than this at this point in time. So there is a large support, huge support for legalization of cannabis use. Cannabis, marijuana, marijuana, use whatever you want. But the bottom line is, I'm just going to say cannabis, but it's the same thing for adult recreational purpose in the US. So again, in 2018, it was 66%. And truly, there's no data at the moment what that percentage is, but I'm sure it has continued to rise as more states have legalized recreational use of cannabis. So as of this morning, medical use update, as of May 18, 36 states and 4 territories allow for the medical use of cannabis products. Adult use, which is another code word for recreational use, although all the states say 21 and older, but tell me that youth can't get a hold of THC any way possible, and certainly online. But as of April 14th, we have 17 states and 2 territories, and District of Columbia have enacted legislation to regulate cannabis for adult use. And what that means is that you can see on the map all these different states that are kind of like a darker green have legalized cannabis where someone would go into a dispensary and they would request a certain amount of cannabis that's a legal limit for that state, and they can buy it and walk out the door without any issue with the law, without any prescription, without any screening, for no reason whatsoever. Recreational use. Now, they may not be able to use it in public or smoke walking down the street, but it's kind of akin to the laws and regulations for alcohol use. They've kind of equalized alcohol use and cannabis use, but we'll see that that's probably not a great parallel thing to do. So in Illinois, again, where I live, in January 2021, adults 21 and older can possess cannabis and purchase cannabis products in licensed stores. So I could now 30 grams of raw cannabis. Well, what does that mean? We have, this is a small picture of 28 grams of cannabis. It looks like this. It's like a baggie. There's some old terms, right? But a baggie of cannabis. And what does that equal out to? It equals out to 60 joints or 100 bowls that you could puff on of use of cannabis. That's a lot of cannabis that I can go in and buy anytime and have in my pocket, my purse, or my car without any problems. Also, for the sake of equity, Illinois is now in the process of expunging records of people who are in prison who had this amount of cannabis or less, so that they don't even have a record anymore, kind of as an equity issue. And a number of states are doing exactly the same thing. But I just want to stress that all those states, those dark green states, that's an enormous amount of accessibility for adults, but it's also an enormous amount of accessibility for youth. Much like adults would buy alcohol for children or teenagers. So are you going to see anybody who's buying these bags of 30 grams of cannabis? You bet you are. And you probably have already. They just may not have brought it up because maybe in that state, such as Missouri, only medical use is still allowed, although that looks like it's changing quickly. But this is just taking the United States by storm. So we want to really be considering what do we need to do to prepare, what kind of information needs to be obtained. The level of research that's needed is extremely high and truly urgent. In Arizona, you can read, it became the 13th state to legalize marijuana after a proposition was passed. Here are the key facts of Prop 207. The key here is that the website that I got this off of is arizonamarijuana.com. Now, of course, it's a business, but it presents itself as providing current legal information on cannabis laws. And who's sponsoring the website? A vape system manufacturer. They know full well that people put THC liquid into these vaporizers. There's no real smell to it, but they get that full effect and efficient effect because they're breathing it in, of vaporizing cannabis or the THC. So this money is driving this, truly. I'd like to take just a minute to look at Canada's experience. They legalized medical use in 2010, and they have countrywide legalized recreational use of cannabis in 2018. So they have a number of years on us of the outcome of legalized cannabis in just the general population. And here is just a snapshot of, this is kind of like their CDC, but you can see health effects of cannabis, short and long-term health effects. What are the effects on pregnant women? Cannabis impairment, cannabis and mental health, addiction to cannabis. They're spending a great deal of time, much like our CDC has spent, on the issues and problems of smoked tobacco and smokeless tobacco. And I'll just put an editorial comment in here. Why in the world did we legalize this if we don't know what it does and what the harms are? And we don't have any guidelines on the proper use of this in medical situations. There are a lot of question marks in cannabis use and what we're going to start seeing in our population. The association, or Canadian Medical Association, actually supported the legalization of recreational use because they saw people who were using illicit drugs paying a lot of money. There were drug crime issues. So they supported having legalized marijuana available for folks 21 and over, but it comes with a lot of warning labels. And they even recognize that while the CMA recognizes that some individuals suffering from terminal illness or chronic disease may obtain relief from cannabis, there remains a need for clinical research, regulatory reviews, and guidance for the use of cannabis for medical purposes. So even with that, they're saying we need to back up. We need to address this, and quickly, because so many of their population have used it. It's just, use has exploded. It hasn't leveled off yet. And I believe we will see the same thing. So looking specifically at cannabis, marijuana, and what the issue is, why the brain just loves it. The the brain chemistry is very close to the drug THC. So much like the nicotinic receptors for nicotine, they recognize nicotine because it's so close to the normal chemical in the blood or in the brain. Same thing with cannabis. People puff it in, or they eat it, or however they use it, that goes to the brain. The brain neuroreceptor grabs a hold of it and creates an outpouring of relaxation and dulling of pain and any number of outcomes, which we'll look at later. But the reason being is that the THC actually mimics what the body already is expecting and produces. And it attaches, the THC attaches to the CB1 and the CB2 receptors. And it also causes hunger, euphoria, and it can cause, it can relieve pain and nausea. Then there's the CBD, that's the non-psychoactive component, one of the components of cannabis. As you can see up here, the flowers secrete 100 plus cannabinoids. And so there are a number of different components in the plant or in the material, but the main ones that people are buying and looking to are the THC, which is psychoactive, and CBD, which is not psychoactive, but it is anti-inflammatory. So many of the number of the FDA approved drugs are focusing in on the CBD component. The problem is that what they're finding is that any one of these cannabinoids is not as effective as the whole group of 100 plus. So people who may have initially taken the FDA approved CBD medications that are approved and found no effect, then they go back to using the whole chemical cocktail of the 100 cannabinoids. So all to say that there is some known about this, but there's a lot more that needs to be known as far as how do all these different cannabinoids affect the whole body, not just the brain, but the different receptors throughout the body, for better or for ill. Again, I'll say this probably 100 times, so much is not known. So from the DEA's perspective, how does it affect the body? And this is THC specifically. So relaxation, lack of inhibition, increased appetite, it affects the memory, difficulty in thinking, and you can see all these, and some of these are high doses of THC, and not so much with the low doses. But that's the problem. If you are using specific types, you can get very, very high doses of THC. And in other types, it's released over time and the effect kind of creeps up on you. So there's as many ways to consume THC or CBD for that matter, as there is foods that we consume or things that we breathe in. Older people prefer the oil and they put it on their food. Youth may be interested in baking the cannabis into brownies or possibly a smoothie. Then there's creams to go through the skin. And then there's different kinds of oil or butter. A whole several hour talk could be on the different forms and concentrations of cannabis. And how to process it at home, or the value of going to a dispensary, or any number of it's a very complex topic, and I'm just highlighting it. But I wanted to make you aware that I would strongly encourage you to include asking about cannabis use in the medical or dental clinic when you do an intake or update a health history. But you don't want to assume if they say that they're using cannabis that they're smoking it. A good many people eat smoke, drink, put on their hands or face cannabis, or specifically THC or CBD. So you want to, in your assessment, kind of tease it out to what kind, how much, how long, and are you using it now? And I have a sample form that to share with you towards the end. But unlike smoking, where there are just a few forms, or tobacco, there are many forms of use, and there's many different levels of THC present. So if you grow your plants out in your backyard and you bring them in and you dry them and you take the flowers and you just make a smoothie out of the flowers, then you have the acidic form of the THCA or CBDA acid form of it. You have to heat it. You have to heat the weed in order for it to release or activate the THC. Once you heat the cannabis flower or the cannabis leaf, then the THC is available for uptake in the brain. So if you just want the CBD content of the plant, which varies per species, not heating it would be very important, although you may just have a little bit of THC in there, but you may not have that immediate effect. I'm probably just confusing you. But anyway, just suffice to say it's complex, and there's a lot of information out there, valid information on the types and the quantities of THC. But one leaf or one group of flowers is not the same as the next. And if you get it from a dispensary, that's a very high level of THC present. And if you get it from your backyard and you're just processing it yourself, it may be a very low concentration, which makes a big difference on how, if you have a toxic effect or you get poisoned by it, or you go and you eat a brownie thinking it's low level and it was a high level cannabis, and now you've got hallucinations and you simply don't know where you are. And then there's butane hash oil shatter dabbing. It could have up to 75, even to 80% THC concentration. So for these different carpels that you can put into the vape unit, or you can put it into your hash pipe. Am I making you want to go out and buy any of this? Maybe it's like, whoa, this would be great. Well, anyway, so you put it into a vape pen, or you have a cartridge that already has the THC and very probably nicotine, because there's that addictive opportunity for the manufacturer. And then you breathe it in and no one can smell the cannabis. No one knows that you're using it. That higher concentration, you can build up a tolerance to it. You can build up a substance use disorder using those high concentrations. Definitely not recommended for youth, and probably not recommended for anybody, because it's just really hard to regulate and get the right dose for the effect that you're looking for, specifically medically. So anyway, beware when you ask people what they're using. If they've recently said they had some hash oil 30 minutes before they came into the dental appointment or a medical appointment, you really want to assess for ability to sign a consent form and ability to even comprehend what's going on in the appointment. They may have taken it to deaden their fear of coming to the dentist. So just be mindful. Talking a little bit of FDA approved cannabinoid based drugs. Here are the different ones currently approved, but again, it's a specific distillation of the THC or the CBD, and what they're starting to realize is that you need a combination of those 100 cannabinoids to get the effect that you're looking for, and no one really knows the concentration, form, or duration of this drug to get the effect that they're going for. So I put this up here for the sake of highlighting the point that many states are legalizing medical marijuana, and now they're legalizing recreational use cannabis for the express purpose of addressing many of these health concerns. Cancer, epilepsy, glaucoma, migraines, debilitating psychiatric disorders such as PSTD, HIV or AIDS, hepatitis C, ALS, inflammatory bowel disease, and you can read the whole list. Just look at that list. And many times the legislators are giving these lists of conditions that THC and or CBD oil can lessen the symptoms or even lessen the severity of the disease. But we have to stand back and realize that practically none of these have any good evidence behind it. So if we're truly looking at evidence-based recommendations, whether it's in dentistry or in healthcare or in medical, what we rely a lot on are anecdotal reports of patients saying, I feel so much better. Now I can move. Now I don't, whatever it is. It just made a huge difference. But let's take a look and see what the evidence actually says. So a good deal of my time has been spent with the National Academy of Science, the health effects of cannabis and cannabinoids, the current state of evidence and recommendations for research. That was published in 2017. And I just wanted to stress, this is it, folks. This is, and currently I've checked the literature and not much more has been moved forward for the levels of evidence. So if we're thinking of strong evidence, moderate evidence, weak evidence, or no evidence, here we have conclusive or substantial scientific evidence that cannabis is an effective treatment for chronic pain in adults, cannabis, nausea and vomiting during cancer treatment, oral cannabis, improving spasticity symptoms in MS, oral cannabis. And then there's moderate evidence that cannabis or cannabinoids are effective for, and then you can read these. Not to say that there isn't going to be more research and we're going to have actually excellent outcomes of cannabis and different combinations of the cannabinoids. But at this point in time, how is it that our legislatures on this limited evidence have passed medical marijuana and then went on to pass recreational marijuana? It defies reason. It throws me back to when doctors recommended smoking a cigarette to lessen morning sickness for pregnant women in the 50s. Maybe it's not the same, but it just feels the same to me that we have rushed ahead way, way, way ahead of the evidence. And now we're going to see what comes of it and then kind of try and reel it back in to make it a reasonable herbal drug that will actually benefit people. But this is all the good or moderate evidence that we have for these conditions alone. If we look back at this list, it just isn't there. The evidence is not there. And then we have to consider cannabis interactions. Again, we have 100 different chemicals in the cannabis plant. And so we have to be mindful that as we're treating patients and doing a health history assessment and treatment planning, we need to be mindful that these the cannabis can have these negative effects on other medications that someone may be taking. Let's talk just a little bit about the consequences of cannabis use and under the influence driving. So here we have age 16 and over in the last 12 months, that would have been 2008 data, alcohol, but look at cannabis, 12 million Americans report driving under the influence. Well, now that doesn't calm me down a bit, especially living in Illinois where we have this recreational use. In Arizona, you should be just as concerned. This is a big problem because I've done a pretty extensive search on how to assess the level of under the influence at car side. If you're stopped by a police officer, they almost have to bring the person back to the station for a urine test because it's a little tricky to do on the roadside. When I was looking at saliva tests, they do say that how much THC is in the saliva at roadside, but it doesn't say how much. And it could be residual and they may not be impaired. So it's not the best indicator. So law enforcement's definitely struggling with this. They need a breathalyzer in essence to assess the level of THC in the person's blood, and then to have an assessment for marijuana, because it's just different than alcohol. But this is going to be a huge problem, especially if they've had a brownie 3 hours ago and they're flying high and there's absolutely no smell. You know, you see the movies where they roll down the window and the poof of cannabis comes out, you know. What movies do I watch, right? But in any case, that can be a telltale sign, but with so many people using oil and edibles, there's really no way to track it down unless you do a urine or blood test, or on some limited level, a saliva test, which is what actually we're hoping to do. I'll share a little bit about that study project towards the end. And then signs of being under the influence, pupils may be dilated, and again, depends on the person, elevated pulse and high blood pressure, but then after a certain amount of time, their blood pressure drops and they're a fall risk. And then you can just kind of see the list. I would just say specifically for older adults, let's say 60 and over. Now that was the generation who they may have inhaled way back in the 60s and 70s. And then they put it aside for a while, but now that they're older and having aches and pains, and my goodness, recreational marijuana is right there. The problem with older adults using cannabis is that it interacts with their medication. If they may have greater episodes or times of loss of memory. It may cause them to be a greater fall risk. So you don't want to assume that the group using recreational cannabis would be your 18 to 30-year-olds. It's just not the case. That's a group that mainly uses it, but it's the use of older adults of cannabis for a variety of reasons continues to rise. So you really want to ask everybody if they use any kind of cannabis products. Looking at the trends of alcohol, cigarettes, and marijuana use, 30-day prevalence, 12th graders, you can see that just even in 2017, and this is 2021, it is dramatically increasing. Cigarettes is going down. Why? Because they're vaping. Well, what's in the vape solution? Well, guess what? It's going to be THC and nicotine. And I keep saying it, frying their brain. So if we have youth come into our clinics that are 12 years old to say 21, we absolutely want to ask them if they're using a vape, if they vape, and what's in the vape. You know, try and keep it low key, conversational. The police aren't going to haul them away, but we need to identify youth who are using these products so that we can prevent them from experiencing not only short but long-term brain damage and possible abuse issues. This is a really important point for screening youth. People who begin using marijuana before age 18 are 4 to 7 times more likely to develop marijuana or cannabis use disorder. So just like nicotine use disorder or alcohol use disorder, they can't stop. They have a tolerance. Not everybody who uses cannabis, of course, moves into this, but the younger they use it, the more likely they're going to have tremendous trouble quitting. And so we definitely want to screen. So I want to touch briefly on cannabis use in oral health. There's very, very little information out there. I'll just say that when I did the literature review a month's worth for the Surgeon General's report on oral health, what I found is that most of the clinical research done on this topic was done in the 70s and 80s, again, before the war on drugs. And it was done on individuals in rehab centers who were dual cannabis users, smokers, and trying to get over some type of drug, say heroin or cocaine. And so a physical assessment was conducted on these different individuals and then looking at their self-report cannabis use. And interestingly enough, the few articles that did that was reviewed by other articles and then reviewed and referenced by other articles, to where the reviews of that initial article had reported the outcomes incorrectly. So we have very, very little actual information, clinical information on cannabis use and oral health. And it truly impacts on oral health in a number of different ways. It may not be the same as tobacco use, and I'll just say smoked tobacco and smoked cannabis have basically the same type of toxins and a higher level of tar in cannabis than smoked cigarettes. So smoked cannabis is not a good option really for anybody. It traumatizes the lungs just like smoked tobacco. It doesn't have the nicotine, of course, unless they put it in there. But it's not a given that, oh, it's just a joint, who cares? Well, it is a big issue. If someone's going to consume cannabis for medical, much better to use oil or edibles or smoothies, something like that, than to smoke it. But we do have some very early signs of cannabis stomatitis, but so much more information is needed. This is a search that I did, a comparison of oral implications of regularly smoked or vaporized cannabis use. So smoked cannabis would be your joints, vaporized would be a vape pen, or an actual, if you can think of a vaporizer, like mist comes out, you can use that to vaporize and breathe in water-laden vapors with the cannabis oil in it. That's a little bit safer than smoked cannabis. But in any case, you can see the associated outcomes with these different oral conditions. But again, these are very early studies, and we really need a great deal more information, because they conflict. And then many of the studies were done on co-use individuals with tobacco, other drugs, and cannabis. So smoke cannabis and risk of cancer, you can see that there are still, when you burn something, it releases all kinds of toxins. So you still have the hydrocarbons, nitrosamines, and so a joint is not safer than a cigarette, and people really don't realize that. They have an elevated risk of oropharyngeal cancer, and maybe a reduced risk of oral tongue cancer when compared to non-users. That could be because they're the CBD is anti-inflammatory, but again, a lot is not known. But it certainly doesn't cure cancer, and there are plenty of YouTube videos out there that talk about that. This was a study that I participated in on looking at NHANES data, those who were vaccinated for HPV and periodontal assessment, and they looked at those two indicators. So did the use of, could you predict HPV being present by the periodontal status and HPV vaccination status? And the bottom line is that cannabis use increases the severity of periodontitis. Now that's extremely important. This is primarily smoked cannabis. There's nothing out there at all talking about edible cannabis or CBD oil. Also, cannabis use promotes progression of HPV positive head and neck cancer activation. There is some basic science that indicates cannabis actually causes the degradation of bone, but they're still not sure what is the mechanism. So again, a great deal of research needs to be done. So we've talked some about the idea of identifying tobacco use, cannabis use, type of cannabis use, and including it in the code in the electronic dental record, electronic health record. We recently at MOSDO added cannabis use and a dummy code is what we call it, so that we can identify all of our patients who self-identify cannabis use. So we're able to much better understand their condition and their dental outcomes. Some patients, because Missouri still is just is not recreational use yet, there's some hesitancy, but it's how you approach it. If you assure them that this is confidential and just to support their health, people are quite forthcoming. This is a form that was created at Eastern Washington University, where they combined tobacco, cannabis, and vaping assessment form. So this kind of goes through that whole how much, what kind, where, what else are you doing? You don't want to play 21 questions with people, but if you have this ahead of time that they could fill out in a confidential way, you can have an enormous amount of information that can guide and lead your treatment planning. And this is a chart that I pulled together that I think really kind of brings home everything I've been saying. By identifying the cannabis use and why they're using it, it will inform our intervention if we need one. So if they have smoked cannabis, it may have between 1 and 25% potency. It takes seconds for it to affect them. It'll peak in 30 minutes. It'll be, they'll have some effect for 2 to 3 hours. And the length of time the THC is detected in the blood is up to 30 days because THC is stored in the adipose tissue. Can you see that depending on when they smoked, what they smoked, and how long ago they did it will affect whether you can continue on in their treatment? Can you give them epinephrine if they have tachycardia because they just smoked a joint 30 minutes before? Or if they ate a brownie the night before, it's not an issue, even though they self-disclose cannabis use. Looking at the edibles, it's very hard to determine the potency. So they may overindulge, or they may not even know how much they're eating. So kind of teasing that out as you're talking with them, again, is very important. But anytime someone's using hash oil, butane cannabis hash oil, they could have gotten a huge dose and it peaks quickly, and they may very well be so completely stoned, to use the phrase, that they really just need, the patient care needs to be delayed. Then there are the informed consent issues. Are they cognizant enough to be able to say, yes, I understand my treatment, and yes, I approve it, if they're actually have signs and symptoms or signs of cannabis use and have indicated use. These are things that dentists have no guidance on. There's nothing out there to guide dentists on how to treat a patient who's indicated cannabis use. Huge problem. And that's true for many health professions. So again, why is someone using? If they're using for medical purposes, they're using the FDA approved medications, or they're smoking a joint a couple times a day, we may want to talk with them about switching over to edibles because the inhaled components may be irritating their lungs and predisposing them to other health issues, cardiovascular issues because of the smoked leaves. For adult users, for medical reasons, we want to make sure that if they have dry mouth, and they're eating candy to try and address the dry mouth, we really want to intervene there to lower the cavities risk, and then also to inform of the potential lung damage. But it's not like tobacco. No tobacco use is good. But for medical use of medical marijuana, we really have to acknowledge why are they using it, and then we tailor our intervention. If they're recreational users and it's legal, if they aren't, and we talk with them, they're not having any ill effects, it's kind of like having a glass of wine a week or a night. There are recommendations, and if it goes over that, then it's moved into substance use disorder. So it's a lot of information to kind of sort out at an appointment, but it makes a huge difference as to what we say and what we do. We can't just say, you really need to quit this, here's the quit line, like we would tobacco. There are similarities, but there are clear differences. As far as integrating this into the curriculum, I would put it right along with assessment and treatment and intervention of tobacco and e-cigarettes. All of those should be a part of substance use curriculum. And you can put it in pathology, pharmacology, all these different threads that go throughout your curriculum. Cannabis needs to be right next to tobacco use. Then for those who would like more information on those who are experiencing cannabis use disorder, there are a few training and educational resources out there that you can refer to. They're state specific because federal, of course, this is an illicit drug. But I think more of these will be popping up as more and more people use. And then there are quite a few educational and training resources. I have to say Canada is way ahead of us on this because they nationwide, they have cannabis use. So I'm going to stop there and thank you so much. I'm looking at the chat. What would you like to ask me? You can unmute or you could put it in chat. Totally up to you. Are you ready to run out and get a joint?
Well, thank you, Dr. Davis. I'm going to go ahead and ask you my question because, I had this in my head. I have this student, and she wants to send out the survey, ATSU wide, following that this one student we lost by suicide this past year. So we had a long discussion, almost like came to blows, over Zoom. It's hard thing about this, including marijuana in contraband substances. So we had a question, what kind of substances do you use? And she felt that marijuana shouldn't be a part of the question because it's normal for people to use. So if our students feel this way, this is only a sample of one, I'm not saying that everybody thinks that way, but what's the correct messaging to have? Because they're also getting information on, like THC products all over, like at general grocery stores, and it's a conflicting message that they're receiving.
Deb, it's a great question. And I think I'll just say again that until the research community, the medical association, the dental association, all the folks we rely on to dig into this and come up with guidelines, to come up with health messaging, much like we did in tobacco. It took us forever to do that, way too long. And now we've legalized it, and we really don't have a reason to have legalized it in the first place because there's so little justification for the use. Why they didn't put THC in a pill, I mean, not the THC specifically, but all the cannabinoids in a pill and give it to people through the pharmacy, I don't know why we've done it the way we have. So I would just say the lack of information, the enormity of misinformation is going to be extremely hard to unwind. And until we do the research that's needed to get the hard data to say anything, it's going to be really hard to be authoritative. in saying yay, nay, maybe. And since there is good use for it, I'm not against cannabis use for medical purposes. We've just thrown open the floodgate, and now we've got this big lake and we don't even know what's in it. And now, I mean, we just don't really have a great way to approach it. It's just like vapor. We really stuck ourselves in a big mess by letting big business get this legalized before we had that information that we needed to make intelligent laws and decisions. Terrible answer, but the thing is, we don't have the information.
Yeah, thank you for that. I mean, I can at least tell her that this is there, that we don't know, so we should advise caution. Thank you.
Caution, absolutely.
Joan,
Hi, Mark.
Hi, how are you? Thank you for the presentation. I saw something recently, I think it was in the lay press, that looked at the states that have legalized medical marijuana and looking at opioid overdose and death, found that in the states that had medical marijuana, the rates had dropped in opioid use. And I know that there's not a whole lot of research out there, but I thought that was kind of an interesting finding, and it was fairly recent. But I did have a question. I guess in Israel, they've done quite a bit of research, and they have found that that use of medical marijuana is very effective with PTSD. Do you have any comments on that, or is?
Yeah, I'll go back to the 2017 report, and then all the data that's come out since then from the US and Canadian scientific community. We really need a body of knowledge before we can start saying anything. And the legislators were fed a lot of individual studies and anecdotal information. And to create a guideline and to create guidance for professionals, we're years away from it. So I really appreciate the research that those scientists in Israel have done, which is great to build on. But no, there's no good proof, enough body of evidence to say anything about anything, except that one slide I showed you of strong evidence and moderate. And then it just drops off the face of the earth after that. So big caution, not that it won't, not that it's not the case, but the opioids, I also saw that, and I'll just say that thank you for bringing that up. This is an expansive topic. And so in an overview, I kind of just touched on kind of the highlights of what might be interesting to us as healthcare providers. Anybody else? Gayla.
Hi, Dr. Davis. Wonderful presentation. Thank you. And I have to rush to my next meeting, but my question was, and it will not be able to be answered here, but where can ATSU make a difference in this whole topic in terms of research and public health education, curriculum infusion? Where can we make the biggest impact into this area?
Well, I thought, you know me, you asked me a question, I'll actually give you that answer. We could have a cannabis use summit and invite individuals who are interested. We need a holistic approach. I've approached the basic science faculty in Kirksville and different folks here and there, but it's not really on too many people's screens, so to speak. But if we had something like that where we could bring in a lot of interested minds from the community health center perspective, dental perspective, and the basic science perspective, behavioral health, and I think we could actually come up with some interesting and useful and doable projects that could start addressing this. And in Arizona, especially since it's now recreational, there'll be a lot more freedom. In Missouri, who knows? But that doesn't mean we can't do something in Missouri. Or even the community health centers that our docs and dentists are embedded in, they may be able to do more, especially out in Colorado, Washington, California. And then funding. It's really going to be important to get people to be honest. You're going to have to give them some reasonable incentive to self-disclose. So that's also an important component. Shameless. I am shameless.
No, excellent answer, and I appreciate your passion. I've got to dash to another meeting, but wanted to thank you so much.
Thanks, Gail.
Again,
I
well done.
appreciate it.
Appreciate it too. Thank you.
Absolutely. Well, I think we're at the time, the hour. So thanks so much for everybody. Contact me if you have any questions.